The purpose of this session is to talk through a case study example for metastatic spinal cord compression. Metastatic spinal cord compression occurs where there is pathological vertebral collapse or direct tumour growth causing compression of the spinal cord, which may result in irreversible neurological damage and possible paralysis. It is therefore classed as an oncological emergency. Around 85 to 90% of metastatic spinal cord compression occurs from extradural tumours. The other 10 to 15% are intradural, either intramedullary or intradural extramedullary tumours. Case study 2 is a 72-year-old male with a past medical history of type 2 diabetes, hypertension and prostate cancer, T2, N0, M0, moderately differentiated 14 years ago, which was treated radically with brachytherapy seeds. He had been discharged from oncology follow-up to GP follow-up 4 years ago with no evidence of disease. He presented to his GP with lower back pain and was referred to the MSK physios. He was assessed by the physios, who identified lumbar back pain and numbness to his right thigh. Given his history of cancer, the physios requested a whole spine MRI as an outpatient within a week for suspicion of bony metastases. And the MRI was reported to show near complete marrow replacement at L4 vertebral body at future risk of potential metastatic cord compression. So the physio did the right thing. They ordered a whole spine MRI. So although this appeared to the GP potentially as a musculoskeletal issue because of the history of cancer, the suspicion was potentially bone mets or cord compression, therefore a whole spine MRI is indicated. And as said previously, this is the lumbosacral part of the MRI, and you can see at L4 the complete marrow replacement of the vertebral body, which extends into the posterior elements on the right side. You can see that on the axial image below. There's associated mild posterior cortical bulge, however no associated juxtavertebral soft tissue and no complete cord equina compression at present. So that means essentially it's an impending cord compression. There's no cord equina compression, the nerve roots are still intact, but there is potential that this may progress. When an MRI is completed as an outpatient as an urgent request rather than an emergency request, it's not always reported on the same day. In this particular case, the MRI was completed and reported on the same day, and that's normally guided by the radiographer who's acquiring the scan, recognising that there's an area of concern and asking for that report to be prioritised. So based on that report, the patient was contacted by the radiology team and advised to attend A&E for urgent assessment on the same day. The MSCC coordinators were contacted by the A&E medic. So further investigations were advised by the MSCC coordinator in this particular example. So a CT tap was required to assess for a primary tumour and or the burden of any visceral disease if it was present, and to assess for bone quality. So in this patient's case, he had a history of cancer, but it was a historically past medical history with no previous evidence of disease. So we had to deal with this as if it was a potentially new malignancy. We requested a PSA as a potential indicator for prostate cancer recurrence, a myeloma screen to rule out myeloma as a differential for the L4 lesion, a neurology assessment to assess the clinical impact of the compression or impending compression, which would help us to guide the urgency of management, and an assessment of pain to support management decisions around patient symptoms and assess spinal stability. So in terms of the outcome of the investigations, the CT tap was reported to show a destructive lesion at L4 vertebral body, causing partial collapse of the vertebra, which is what we knew from the MRI, and no primary tumour site identified within the thorax, abdomen or pelvis. The PSA returned as insignificant, so no PSA evidence that this was a prostate recurrence. The myeloma screen, the initial results came back normal. The immunoglobulin G levels were normal, and A levels were normal, and M levels were normal. The neurology assessment showed that he had some reduced power in his right hip, otherwise neurology was intact. Bladder and bowel function was normal. Power in other limbs was 5 out of 5. He had no saddle paresthesia, and reflexes were present. He He was initially nursed flat in A&E because of the slightly reduced power in his right hip, but he was assessed through graduated sit-up up to 90 degrees, which means assessing neurology and pain symptoms as the person is progressively inclined. Symptoms were assessed at each increment, and there were no complaints of increased pain or neurological deficit on assessment by the doctor in A&E, which meant that they were able to mobilise safely at this point. There was an assessment of pain, and he had no increased pain on mobilising and no clinical evidence of spinal instability. So there was no indication at that point for a spinal orthosis or brace. So depending on the trust where the patient is and the day of the week and the time of the day, some of this initial management planning is supported by acute oncology. So where we were in terms of formulating a management plan, there was no solid tumour primary on the CT and the myeloma screen was negative. So there was no clear indication as to the origins of this L4 lesion and no absolute confirmation that this was a malignant lesion, although it appeared so on CT and MRI. So a biopsy was indicated to support management decisions around the L4 lesion and how to treat it, and also ongoing oncology or potentially haematology management. So the implications for the patient is that now we require a biopsy, there's a delay in management to await for investigations and the outcome of the investigations. He would then require a neuroassessment, and the patient needed to be aware to alert the clinical teams with any changes in pain or symptoms whilst waiting for further investigations to take place. So it's necessary for those investigations for us to be able to support the patient with their potential new cancer diagnosis going forwards, to be able to offer cancer treatment to them. But it does mean delaying treating this potentially medical emergency. So there's a balance between histological confirmation to inform the ongoing management and the window of time to treat the impending cord compression without the patient deteriorating in condition. And there's no absolute in terms of that. If the patient started to deteriorate rapidly as a result of the L4 compression, it may be necessary to treat them before the biopsy is acquired or potentially before the histologies returned from the biopsy. So in this particular case, there's two indications for asking for a spinal surgical opinion. The first is around the instability of that L4 lesion. Is the patient an appropriate candidate for spinal surgery? And if not for spinal surgery, support may be required from the spinal surgeons in accessing a biopsy of that spinal lesion. So an Orion referral was completed, and Orion is currently the referral portal to allow discussion with Walton for neurosurgical opinion. So the patient was referred to Walton for consideration of surgery because they had no spinal instability pain and stable neurology and were awaiting the final myeloma screen results. The initial outcome was not for surgical intervention, but a biopsy could be supported if the myeloma screen was negative. The patient was discussed with the haematology team at their local acute trust, who suggested a bone marrow biopsy would be appropriate to rule out oligosecretory myeloma. But also a CT-guided spinal biopsy was required, which needed to take place at the Walton Neuro Centre, and that was facilitated through the MSCC pathway, where we can expedite the urgency of a biopsy to take place. So the outcome of the biopsies was that the initial histology report from the CT guided biopsy, which returned 4 days after the guided biopsy. So you can see now that the pathway isn't always as quick as a 24-hour turnaround when a potential cord compression is identified. That showed that features were most in keeping with a plasmacytoma, and the specimen was referred to HODS for diagnostic confirmation and molecular phenotyping. The HODS opinion returned 11 days from the initial histology and showed that the appearances of the sample are those of plasmacytoma or plasma cell myeloma. So now we have two sets of information. The first is radiographically, this appears to be a solitary L4 lesion, and histology is returned suggesting this is potentially a solitary plasmacytoma. So quite often a PET CT is then indicated as part of the workup. So this patient will be now accepted by haematology, And although we have clinical oncology input into the MSCC pathway, sometimes for these patients we seek extra advice from a haematology specialist clinical oncologist. So it is really very much a multidisciplinary approach to managing this patient who has a potential medical emergency, but also has a diagnosis that means fairly radical treatment may be appropriate. So the PET-CT was acquired, and there's often a delay in accessing a PET-CT. And the PET-CT was then reported to show non-FDG avid L4 plasmacytoma, but there was a lack of metabolic activity on the PET that the radiologist suggested may be due to interval treatments such as steroids and or radiotherapy. And suggest correlation with recent treatment history. So we knew that the patient hadn't had radiotherapy, but they had had initial steroids at the point of presentation with prostate cancer and an L4 lesion with some mild neurology. So that may be in keeping with the steroids that were given at the start of the process. So it showed that there was limited exclusion value for detecting additional sites of myeloma on the PET-CT in this scenario because of the lack of uptake in L4, which we had seen to be likely malignant. So for this patient's pathway, there was a wider team involved. So at Clatterbridge, this involved the MSCC coordinators, the MSCC cord consultant, so the consultant clinical oncologist for the week, and the haematology specialist clinical oncologist. At the acute trust, at the point of presentation, it involved the medical teams in A&E, acute oncology and the haematology consultant, and at the Walton Centre, the consultant neurosurgeon and the MSCC spinal specialist advanced nurse practitioner. So this presentation was likely plasmacytoma, and there was no urgent requirement for spinal surgery. So that was based on the NOMS, so there was no neurological deficit. They had a low-grade ESCC, so it was an impending cord compression rather than a cord compression. It was a radiosensitive tumour, therefore radiotherapy would be an effective management for it. And the SINS score, spinal instability, was 7, so that was potentially unstable, but the patient had no instability pain to suggest that they were clinically unstable. So the management plan was for radiotherapy, and in the case of plasmacytoma, this is done as a higher dose targeted radiotherapy treatment than a normal standard emergency spinal treatment, and a dose of 45 gray in 25 fractions over 5 weeks is given using a conformal VMAT plan in this case to give the high dose to the vertebral body and encompass all of that disease, including the impending compression on the spinal cord.